Hello, dear students and esteemed learners. Welcome back. Welcome to my course on Sociology of Health. This is lecture number 37, and this week we are talking about health policies in India. And in the previous lecture, we had a general understanding on why do we need to talk about social policies and health policies. We tried to understand the way things were moving before the implementation of the first health policy in 1983. We talked about all situations prevailing at that point of time. And now, today, we are going to talk about the second national health policy, that is the National Health Policy of 2002. And we will try to cover the background and thrust areas in today's lecture. This is a large policy document and there are several issues related to this. So, we will try to cover this policy in two lectures. Today, we will talk about the background in which this policy got implemented and the thrust areas. And in the next lecture, we'll talk about the important policy provisions and an analysis related to that. So, the concepts that I have covered primarily, we are talking about the policy itself. So, there is nothing new concept. I think you would be familiar with most of the concepts that we will discuss. So there are two or three contexts that we will talk about. First, the background, then the financial situation prevailing before the health policy of 2002, and then the important thrusts. The financial aspects are very important in having any policy basically, because when you are talking about the future or the vision, then for having those kind of vision, you need to have the finances also, because for every program, nation state need basically budget, and very often the policy priorities are decided on the basis of the availability of the budget and the funding. So we'll talk about these things in the next few slides. So let's go to the first slide. Background of the National Health Policy 2002. We all know by now that the first health policy got implemented in 1983. So there were 20 years and in between these two policies, and so many things basically happened in between. We need to have a fair understanding of all these things, because all these things got reflected in the policy document. Let us have a quick look. The eighth plan, basically 1992 and 97, identified human development as its main focus, with health and population control listed as two of the six priority objectives. So, we have been talking about human development, and we stated that in the Millennium Development Goals, which were adopted in 2000, that we have already discussed, the focus was on human development. The decade of 1990s was basically the decade of human development and human development index. And as we know, human development means taking into consideration the three important development parameters, which are basically income, education, and health. Health is getting reflected as longevity of life, right? So, the 8th plan document talked about population control and health as two important priorities, and it had the human development approach. Of course, the population control paradigm is one of the important paradigms prevailing in India. As we discussed in the previous lecture, that the decade of 1970s has witnessed some of the extreme measures which ultimately failed also in the discourses of achieving the goals of family planning, right? So in the decade of 80s, there was change in the direction of population control programs, and it was realized that development is the best contraceptive. And so we will try to see that how the development approach along with health approach basically brought a paradigm shift even within the population policy, right? So these were the things. Then there was a very important development, and that was basically related to the panchayati raj institutions and basically the local self government. We are aware of the fact that the 73rd and 74th constitutional amendments got passed in the decade of 1990s, and there was a whole new trajectory of empowerment of the local self governments, both in the rural and urban areas. And then there was another important development that was related to first the onslaught of HIV and AIDS, and then the way the world responded to that, and government of India also responded to that by having the National AIDS Control Program. So that is very important. And then in 1993, the National Nutrition Policy was also formulated. So because in the 83 policy itself, it was realized that the nutrition related situation is a very poor, and women and children were actually suffering the most. Now, the decade of 1990s is known for multiple things, but one very important thing is related to the arrival of the trio that is known as liberalization, privatization, and globalization era. And time will not allow us to talk about these things, but you can read about these things uh, if you wish to know about those things separately also. But in 1990s, because of several global events, the thrust for globalization and privatization and liberalization became the core thing, and various nation states basically followed the path of this liberalization, globalization, and privatization. And these things were having its impact on the national policies also. In Indian context, basically in the domain of health, three things are very visible. One, increasing participation of the voluntary organization and the private corporation in the domain of healthcare, and that is also seen as the beginning of the privatization of health. So if you want to track the privatization of health, then definitely the decade of 1990s is playing a very important role in that. The second important thing is the quality of care at the tertiary level. It was increasingly realized that the primary care should be taken care of by the government, and the secondary and tertiary basically could be taken care of by the corporate or the private sector, right? So at this level, there was an increasing understanding that the tertiary care could be taken care of by the private sector, and the quality of care should be taken care of and monitored. Then the third important thing is basically the user charges even at the public health care centers. The public health care center or the government hospitals or the clinics, earlier they were not having any kind of user charges, and now there is beginning of taking some user charges, like when you are getting some kind of pathological test conducted or some kind of radiological tests conducted, then the hospital will have a nominal user charges to meet the contingency and other requirements at that level. So that is known as the user fee charges. So that is an important event because that got initiated, and that is actually seen a move in the direction of privatization, although at a very initial level. Then we had the International Conference on Population and Development, the ICPD conference of 1994. We talked about it in some of the earlier lectures, so you can see it there, but it's important because that has influenced the national health policy of 2002. Then the Millennium Development Goals were already there. 2000, basically the turn of the millennium is basically uh, the turn of the millennium has witnessed the adoption of the Millennium Development Goals, and there were three very specific health related goals in the Millennium Development Goals, which were basically reducing child mortality, then improving maternal health, and then combating HIV, AIDS, malaria, and other communicable diseases. We have talked about the Millennium Development Goals, so I think you are having a understanding on these things. And so we can say that the way the Alma Ata Declaration has played a very important role in the coming into existence of the 1983 health policy. So that way, the Millennium Development Goals also played very important role in the coming into existence of the National Health Policy 2002. Right. Very briefly, we would like to have a kind of understanding about the health statistics prevailing at that point of time. We talked about this in one of the previous lecture also. So you are already familiar with this, but basically this is a reference point that when we started to have this national health policy, then at that point of time, largely that kind of situation was prevailing, that the life expectancy was around 64.6 years. And other statistics are here that you are familiar. Now, a very important component that we need to talk about is the financial situation prevailing before the National Health Policy of 2002, and which was having a kind of impact on the policy. Because we talked about the triple forces, the trio forces of liberalization, privatization, and globalization that has made a paradigm shift at the policy level and even at the level of the functioning of the government in the decade of 1990s. So that had huge impact in the direction of policy making of the nation states, not only in India, but of course in other parts of the world also. So we are talking about the situation that was prevailing in India, right? So let us talk about some of the figures which are very important for having a comprehensive understanding about the situation or the scenario. The aggregate expenditure in the health sector was 5.2% of the GDP. So the aggregate expenditure means the total expenditure basically. So at the national level, whatever expenditure was there in total, so that was actually 5.2% of the GDP, whatever expenditure related to health basically, right? And then out of this aggregate expenditure, about 17% of the aggregate expenditure was public health spending. Public health spending means spent by the government, right? So public health is not necessarily always the health machinery of the government, not always necessarily, because public health is something more than that. But when we say public spending, that means basically we are talking about government spending, right? So need to have some kind of understanding about that. So the public health spending was around 17% of the aggregate expenditure, and the balance being out of pocket expenditure. So if 17% was the public spending, that is the government spending, then 83% was basically out of pocket expenditure. Now, what is this out of pocket expenditure? Basically, when people spend from their own pocket, their own money, this is known as out of pocket expenditure, right? That means the government is not funding that part. People are taking care of on their own from their own saving or whatever way they basically they have whatever way they have collected that amount. In one of the forthcoming lecture, you will get to know that the what are the components of this out of pocket expenditure. It's not always necessarily coming from the saving. Very often people take loans and debts also for meeting the cost of the care, and that is having very uh, serious kind of complication in their budget, right? But as of now, we can understand that the government was having 17% spending or expenditure in the overall the aggregate expenditure. Now, the central budgetary allocation for health over this period as a percentage of the total central budget has been stagnant at 1.3%, while that in the states has declined from 7% to 5.5%. Now, there are two important things here that when we are talking about the aggregate expenditure, then we have already seen the share of the government and the public through the out of pocket expenditure. Now, how much amount or what proportion of the GDP basically or the budgetary allocation the government is spending on that public spending? So that is around 1.3%. That may vary, sometimes 1.2%, sometimes 1.4%, sometimes 0.9% also, but that is around that, right? So this gives you an idea that the overall spending by the government is around 1.2%, 1.3%, or 1% of the GDP in the domain of public health. Now, under the constitutional structure, public health is the responsibility of the state. We all know that although it is in the concurrent list, but the central government is having the role like making the policy and then having some kind of missions and specific programs alike. But on the day-to-day basis or that at the day-to-day level, most of the spending is coming from the state governments. In this backdrop, the contribution of central resources to the overall public health funding has been limited to about 15%. So, as we stated, it was around 17%. So, a generalized situation is this that it was around 15%, and the contribution of the states vary, and so the indicator of health in different states also vary. So, when we have limited spending from the central government, then the remaining spending is coming from the state government, and here is a situation because there are good number of states in India, and the states are not spending the equal amount or in the same ratio. Some states which are richer states, they are spending much more, and then there are other states which are financially not that viable, so they are spending much lesser. Even if the proportion may be high, but the total amount could be much lower than the other states. So that creates a kind of imbalance, and that is why we get to know the kind of disparity or the differences existing at the level of the various states or the interstate disparity. So this is also related with the budget and the financial conditions of the states. Now we come to the National Health Policy 2002, and we will try to understand the major thrusts. In today's lecture, we will not talk about the specific provisions because time will not allow us, but let us try to understand what were the core areas that this policy were actually talking about, what were the major thrusts. This policy reflects the prioritization of the human development approach as was reflected in the Millennium Development Goal. Now that is very important. The 2002 policy is talking about and prioritizing basically human development as was getting reflected in the Millennium Development Goals. And you may remember in one of the lectures, at length we talked about this human development approach. Now, what very important thing basically related to this is the measurability. Basically, when we are going for having policy making, then we do need some kind of statistics so that we can have some kind of projection, some kind of calculation. So, measurability is a very important thing. And in the human development approach, in the decade of 1990s, at the level of the global agencies, an index was developed that is known as the Human Development Index. We talked about it earlier, right? And that Human Development Index was basically constituted because of three components: the income index, then the educational index, and then the health index in terms of the longevity of life. So the the measurability aspect was very important, and because the Millennium Development Goal has already focused on that, and so that was a natural choice for the government to follow that, right? And there are other international dynamics also that we need to keep in mind. So now we can understand. That means when we will see the provisions related to the National Health Policy 2002, we will see that there is a focus on a kind of interconnectedness, interrelatedness among all the three parameters, right? Because health alone cannot make the kind of differences that we want to see. For that, basically, there is a need to have a comprehensive understanding of that. And health is an integral component of development. So we cannot basically see health in isolation. That kind of understanding is basically building up. Now, how this is different from the kind of understanding that we had earlier. So you may remember earlier we were talking about the vertical disease control programs or the vaccination or immunization programs. So at that level, the immediate goal, the priority was to have a control over the disease. And the entire discussion on health and healthcare and development related to health was primarily getting reduced to control of the disease, control of the epidemic, and then getting people vaccinated so that they can have the capacity to fight with the disease, right? So the preventive aspect as well as the curative aspect, right? But now when we are having a policy, then because a policy needs to have long-term vision, so now we are trying to address all other related issues. It also reflects the large-scale macro and structural changes which took place in Indian economy and polity because of our exposure to the trio of liberalization, privatization, and globalization. So, of course, we already talked about the structural changes. Basically, structural changes means the structure of the economy. So, India was primarily following the regime which was often identified as the license regime, right? Because everything was existing under the government control, and the government was primarily taking care of almost all possible sectors of the economy. The government was not only a regulator but also the provider of the services. And so India in 1990s had performed very miserably in economic terms, and then there was a need of basically taking data from the global agencies. There were issues related to forex reserves, basically foreign exchange reserves, right? And then India had approached some of the global agencies like World Bank and IMF for taking some kind of debt. And then those global agencies had created some kind of terms and conditions, and some of those were related to making the economy more liberal, so that there can be a scope of making some kind of intervention, not intervention exactly, but basically having a kind of partnership with the private sector, right? So the government should not remain the only player. There should be increasing involvement of the private players, and the government should reduce its role as a provider or as a producer, and should focus more on as a regulator. So that kind of change was there, and that is basically generally identified as the macro and the structural changes. So that kind of changes taking place in the economy was also having some kind of impact at the political level. So at the political level in the decade of 1990s, there were again important changes. We have seen change of several governments within a short span of time, right? So political instability was also there. Then this policy basically talks about a phased time bound program for setting up a well dispersed network of comprehensive primary healthcare services in India, right? So we had a full discussion on the primary healthcare when we were discussing the uh, health policy of 1983 and the Alma Ata Declaration, right? So that focus is still there, and then we have already studied about National Rural Health Mission, and that actually that program was implemented in the year 2005, and initially it was meant for remaining relevant up to 2012, and then it got extended afterwards, right? So the kind of program in the form of NRHM came into existence because of this kind of thrust of this national health policy. And as we are also aware of the thing that by 2013 the National Urban Health Mission also came into existence, and then the umbrella mission, that is the National Health Mission, also came into existence. So basically the focus was on setting up a well dispersed network of comprehensive primary health care services. And then very important points I have mentioned here in this slide: an integrated network of evenly spread specialty and super specialty services, right? This policy is focusing on an integrated network of evenly spread specialty and super specialty services. Right. So in the previous point, we talked about the primary healthcare, but primary healthcare is important, but that is not sufficient to meet the healthcare needs of the population, because people do need a specific kind of or a specialized kind of services when they are having some specific disease, right? So for that, specialty and super specialty services were also required, and this policy is basically talking about focusing on that. And then there is another important point, the evenly spread. That means those facilities should not remain confined to few states or few metropolitan cities, and there should be an even distribution or spread. Then encouragement of such facilities through private investment for patient who can pay. Now there is another important point. When we are talking about the specialty and super specialty centers, then the government is having the limited funds. We have already talked about that. Then the point is this, that how can we have those specialty centers? So the policy says that there can be a provision for the patients who can pay. That means at a broader level, we see that in the state or in the country, there are people who can afford good quality services even at a higher price. Then they should get the facility. That means there should be availability of the resources at the level of the private providers also, and of course that may need some kind of fee structure, and that is why this provision is there, that who can pay, right? That will not be mandatory for all. So those who cannot pay, they may still rely on the government facilities, right? But those who can pay, they can get the services from the private specialty and super specialty centers. And then the third point, so that the draw on the government's facility is limited to those entitled to free use. So if the government has made a provision of making available the specialty and super specialty services provided by the private sector, then a good proportion of the people, of course, those who can pay, will go to those private sector hospitals, and that way the rush for the limited government facility centers will be much lesser, and that way those who are entitled for those, or those who do not have the choice of going to the costly services, they can of course get benefited by that. That means it will be helpful in meeting the needs of those who can afford to pay, as well as those who cannot afford to pay, because they can get the services from different centers. And that is why, taking care of both the kind of needs, many new All India Institute of Medical Science, generally we say the new AIMS, right? Because All India Institute of Medical Science is one of the top quality medical college and center for tertiary care, situated in New Delhi. But on the model of that AIMS, the government basically planned to have new institutes which can provide that kind of service, and which will remain evenly distributed in many states, right? So that it can take care of the regional needs and requirements, also can be helpful in reducing the regional disparity, and they can provide basically a kind of model of services for the other hospitals, of course, at the government level as well as the private level. And along with that, many new corporate super specialty hospitals also came into existence. So this policy document basically had a provision related to all these things. So these were the important things that I wanted to discuss in today's lecture. I hope you got a fair understanding about the background things which basically played very important role in the development of this national health policy, and then you have understood the financial requirements and financial positioning, and then the important thrust areas. So in the next lecture we'll talk about the important provisions which were made in the national health policy 2002. So till then, take care. And here is one small think about this problem and activity question. Just have a look and think about this. So we will meet in the next lecture. Until then, take care.